Hi, everyone. I'm Victor Armstrong, and I want to welcome everyone to our conversation on suicide awareness. This will actually be the first in a series of 5 conversations that we'll be having. So I want to thank our guests with us today. My panelists are Dr. Michelle Laws, Dr. John Draper, and Dr. Christine Moutier. We want to thank them for being with us and also thank all of you for being with us today as a part of this conversation. We believe this is a very timely conversation to be having. We know that our nation is hurting right now. We're in the midst of a pandemic, and we've also seen the aftermath of a lot of the social and civic unrest that's been taking place in our country. So we thought now is as good a time as any to talk about the impact of all that we're seeing on our mental health and mental wellness. We recognize the role that anxiety can play, particularly in a time when we are dealing with social isolation, uncertainty, and other things that are going to impact our mental wellness. So our purpose today is to talk about these challenges, share resources, but also to build some collective space for healing. Also, as a behavioral health professional and an advocate, I believe that we should always be guided by principles of trauma-informed response, where together we, as a community, seek to realize the widespread impact of trauma as it relates to COVID-19 and the social justice issues in our country, and its impact on our mental health, as we also share resources to create paths for healing. So we're going to spend the first part of our conversation talking with our panelists, and then we're going to open up the conversation to our participants so that you can have questions. You can also submit questions online, which we can attempt to answer as we go through the conversation. So first, I'm going to ask our panelists if they would introduce themselves, and then we'll dive into our discussion. Let's start with Dr. Laws, followed by Dr. Moutier, and then Dr. Draper. If you would just introduce yourselves to our guest today.
Thank you, Victor. It is a pleasure to be on this panel with the other distinguished guests. I am Dr. Michelle Laws. I am one of the assistant directors for the North Carolina Division of Mental Health, Developmental Disabilities, and Substance Abuse Services. And I am also a part of the Secretary for the Department of Health and Human Services, Mandy Cohen, along with the Deputy Secretary, Cody Kinsley's COVID emergency response team. It's the whole department effort. I just wanted to lift those two up. And we are responding to the COVID-19 pandemic here in North Carolina in a very thoughtful and intentional and serious way. And so I'm glad to be a part of that team, specifically one of the co-leads for the historically marginalized populations team doing some of that work. So glad to be here.
You. Dr. Moutier?
Yes, thank you. Thank you, Vic, and great to be here with you all, and for the viewing audience as well. Really looking forward to hearing your thoughts and questions. I'm Dr. Christine Moutier. I'm the Chief Medical Officer at the American Foundation for Suicide Prevention, and I work with and represent people who have experienced mental health struggles, who have experienced suicide loss in their family, among their loved ones, and who are now, all together, we all are trying to create change and advocate for a world where it's safe to talk about anything that we're experiencing, any of life's challenges, which for everyone, we all have mental health. And so that includes our mental health challenges. There should be no stigma. And right now really feels like more of an important time than ever that we talk about those things and maybe open up some new dialogues where we haven't had a way to do that before. So thank you again, Vic. I'm looking forward to this conversation.
Thank you.
Vic, thanks for inviting me. Great to be here with Michelle and Christine. I'm John Draper. I'm the Executive Vice President of National Networks for Vibrant Emotional Health here in New York City. That also includes being Executive Director of the National Suicide Prevention Lifeline. We also oversee the Disaster Distress Helpline, which is getting more attention now. It's kind of a sub-network of the Lifeline, which is really there to help people in populations that have been impacted by catastrophic events that can affect your mental health, such as what we're having right now. And we also work with the Veterans Crisis Line. to help them administer the Veterans Crisis Line Network. And it's a pleasure to be with you all today and look forward to our conversation.
So thank you all three. One of the things that I've had the good fortune to experience throughout my professional career is to work with some very talented but also very passionate people who advocate for many of the same causes that I advocate for. And so today I have the opportunity to say that I'm working and talking today not only with colleagues but also friends. And so I appreciate this opportunity to have this conversation with you all. So let's get started. We have all seen the events that have been unfolding over the past several weeks. We've seen the impact of COVID-19. We've also seen the protests that have been occurring in our streets. So let me throw this first question to you, Dr. Moutier. Let's start by talking about the signs and symptoms that someone is contemplating suicide. How can we recognize that someone is suicidal, and then what should we do if we suspect that someone is having suicidal ideation?
Thanks, Vic. Because if there's nothing else people take away from this, it's that we all have a role to play in preventing suicide, no matter what your training, your background, or your roles in life are. It's important to realize that all of us as human beings struggle at different times. And we haven't created a world yet, though, where it's necessarily very easy to share those struggles. And so really what I want to impart is that while there are some classic signs and symptoms to look for in terms of withdrawal, despondency, really signs that someone is feeling overwhelmed, hopeless, or like trapped, or like they're a burden to others, all of those would be pretty clear indicators that something has significantly shifted in their mental health, and that you could approach them and actually ask them if they are having thoughts of taking their life. That is a profound type of moment, but it's an opportunity to allow somebody to share their distress in a way that's safe for them, in a way that may be therapeutic on its own, just that they're able to disclose that, not feel judged, and be ready to continue on that path of help seeking and kind of learning themselves about how they tick and what they need in terms of gaining more resilience and having their mental health needs addressed. So it's really, I think, important to, number one, just take stigma out of it the best that you can, to ask that question about suicidal thoughts without any extra connotation of a judgment. And so you might actually need to actually say it in a way that ensures that the person knows what you are thinking, which is that you love them no matter what, that there is unconditional support regardless of the challenges that anyone is facing. But we have to say those things, because when you're the one in distress, your mind goes to some very judgy places for yourself, and so it makes it extra hard to open up. And I think the last thing I just want to say is that there are culturally bound ways that we express our mental health distress, and individual ways as well. And so any indication where your radar goes off telling you that something does not fit with their usual patterns of behavior or the context that you've known them in, that could be an indication that you just set up a time to have a private, caring, and supportive conversation with the person.
Absolutely. So let's expound on that a little bit. And I open this up also to Dr. Laws and Dr. Draper. What advice should we give to people who want to be a support to friends or family members, and particularly folks that maybe they know that have had a history of anxiety, depression, suicidal ideation? When we're now in this environment where we're more socially isolated, there's anxiety because of loss of employment. How can we support friends and family members in times like this?
It's a great question, Vic, and it is a very special time for us to be reaching out. Even though we're physically distant doesn't mean that we should be socially distant. I think many of us are learning the miracles of Zoom and Skype and FaceTime in ways that we probably underappreciated them before. Seeing y'all's faces is now, it's a beautiful thing that I can see you all and be with you all, but not be with you, but I still feel connected to you. And that's, I think, what's happening in ways that we haven't seen before. in our culture, that we are reaching out using technology. It's not our favorite way of doing it, and we've probably underused it and underestimated it, but now that it's about what we got in most circumstances, we've got to use it. The other things I would say, aside from connecting and making a schedule to connect with the people that are really important in our lives, and I don't know about y'all, but I have been staying connected with people in my life and friends regularly in ways that I haven't before, just because we're going through this crisis. And I would really recommend that everyone do that. But that's also part of a routine that we need to establish. And routines are extremely important in a time where things are very uncertain, and things are changing. The one thing that won't change necessarily is our routine. It keeps us grounded from day to day. So it's not necessarily Groundhog Day. We at least have something that we know we're going to do every day, and make a schedule of things that we want to accomplish every day in terms of tasks. The other thing I think is really important for people is that we remind ourselves that in a time where there's so much we can't control, that we should focus on the things we can control in our lives. There's various areas of wellness, anywhere from emotional, intellectual, spiritual, occupational tasks we wanted to accomplish, little things that are within our control that we can say, now is the time I can actually do something for myself that I haven't really been able to do in terms of my physical health or my emotional health. So we can redirect each other to the things that we can control and say, let's focus on what we can do with this time that is different than how we usually do things.
Absolutely.
Yeah, and the only thing that I'd like to add, excuse me, is that we've got to normalize the conversation about mental health and about mental illness. And Lucille Clifton, the great poet, once said that, "Come celebrate with me that something has tried to kill me every day but failed." And so I think normalizing it in our conversations with our family members and loved ones, that we all have felt a certain way. We all have felt at some point a sense of hopelessness, a sense of anxiety. And so normalizing it by recognizing that it's not a unique attribute or feeling or characteristic or trait or experience of just one person, but that we're all feeling this or have felt where we needed to reach out to someone or where we needed extra help. Making it through our day. And the other thing I want to mention is we, as professionals working in this space, have to, I think, really stay mindful of the fact that COVID happened on top of already a mental health crisis that was going unattended and systems were ill-equipped to respond to. And so by really thinking about how do we build the system that was weak already, how do we continue to build that system and those supports? People still need substance use disorder counseling and treatment. We still need community crisis beds. We still need alternatives to involuntary commitment that are humane and that support people where they are with their needs. We still need, so I can go on and check off the list. We still need to stand up and to fund peer support services and peer-led organizations. So I think, the anxiety is real, but it didn't just happen with COVID and the social distancing piece. And the exacerbation of mental illness didn't just occur in this time of this pandemic. It has only heightened our awareness and shined a light, just like it has for other health disparities.
Yeah, you all brought up several great points. I love the point about Dr. Moutier, the point that you made about in your space, in your culture, there are certain things and certain ways that people respond. So you have to be mindful of when things happen because they may look different in different environments. Dr. Draper, I love your point about routine. It is so hard right now for us to stay in a routine, and we are creatures of habit. And I know for me, not being able to get up and go to the gym every morning, it has taken a lot of getting used to. And then, Dr. Laws, your point about there already being an under-resourced mental health system to start with, and then adding the COVID crisis on top of that, just further stretches a system that was already overstretched. So, kind of keeping all those things in mind, I want to pivot a little bit to first responders. I know that we have clinicians probably in our audience today. We have nurses, we have social workers, and we also probably have, law enforcement officers and firefighters. So let's talk a little bit about self-care, the importance of self-care and supporting colleagues, because again, if we already have an under-resourced system, it just seems like self-care and taking care of each other is going to be all that much more important. So what advice do you have for how we can support colleagues in mitigating stress, but then also organizational leadership? What's the responsibility of organizations and employers with regard to suicide risk, and particularly with our frontline workers during the COVID crisis?
Well, I can kick us off that I actually got my start and my interest in suicide prevention broadly related to the loss of physician colleagues to suicide earlier in my career. And so it became something of a passion to try to think through why would individuals who actually do have access to care and support and medical and psychiatric treatment have a higher risk among themselves. And I think what we've seen and has been discussed quite a bit, which is good during the COVID crisis, is that frontline workers across a lot of different industries, including, of course, in healthcare, are being pressed upon in a way that will wear through our reserve of resilience, regardless of how robust it is. And so, but one of the key points that I've learned really squarely is that ultimately it's a shared responsibility between individuals, self-care and for each other, but also related to institutions and organizational leadership. And when it tilts one direction or another, it gets very off track. This has to be a shared responsibility where each entity in all of our roles, that we're sort of collaborating together to try to lead to change. And it does include true actionable strategies at the organizational level with regard to policies and access to mental health services, and really creating culture change so that these are dialogues that we can have informally, boots on the ground, as we're getting stressed and sort of running out of steam, reaching burnout or other more significant forms of depression, anxiety, PTSD, or suicide risk.
Thank you for that.
And I'd also add community responsibility too, right? So I like that an ad I saw of nurses and CNAs saying we come to work to help you. Stay at home to help us, right? So this notion that for COVID, we all have a responsibility to play. So we do need people practicing the appropriate public health precautions to prevent COVID and its spread, right? And so we do need you, as we say, practicing the 3 W's here in North Carolina: washing your hands, wearing a nose and mouth covering, and also practicing safe social distancing at least 6 feet apart. And I say that in relationship to the frontline workers. The more we show a reckless disregard to those practices and guidelines, the more we put them at risk, right? Their health at risk. And in terms of self-care, and I'm particularly thinking about persons like the paraprofessionals, so the CNAs and the frontline workers who really who have no other choice, right? We know that African Americans and other people of color make up a large percentage of the frontline workers and those who are not able to work from home or to telework. And so for those professionals and paraprofessionals and essential workers, I would recommend that if you are beginning to feel heightened sense of anxiety and depression or any other form of mental health, distress, I call it, during this time, right, that you do seek support. And in North Carolina, we have a Hope Line, And we also have a Hope for Healers line for our for workers who are out there doing this work. So again, it goes back to normalizing and making it okay to ask for help, because a lot of people from different cultures, asking for help is a sign of weakness, or asking for help indicates that there's something wrong with you that cannot be fixed, right? That there's something that needs to be. And so I'm not going to, people may, Irving Goffman's work looked at stigma as a spoiled identity. So it's something that I'm ashamed of. And so I want to say, for those who are watching, that there's absolutely nothing to be ashamed about, and that if you are feeling like you need to speak with a mental health professional, reach out and get help. And then also, if you're able, and I know even not working is a privilege, sitting out and taking sick leave and so forth, if you have it. If you have paid sick leave, that's a privilege in and of itself. But taking a time out and saying, I just can't do this anymore. I do need to do something different. I need to be around different people. I need to expand my social network, or partake in some physical activity, walking, running, yoga, whatever it may be. But recognizing when you are at that point where you need help, and not forcing yourself to press and work beyond that space.
Thank you.
Vic, this is a very serious and important question you're asking, because for example, physicians have one of the highest rates of suicide of any occupation out there, and now we're throwing them into this situation, which is unparalleled, where they're being exposed to incredible amounts of loss and trauma, really. Mm-hmm. But aside from them, there's also mental health clinicians, and the fact is, all of us are not great necessarily at helping ourselves. Many of us tend to, whenever we're under stress, it's like, how can I help? That's our coping mechanism in many ways when situations are stressful, is how can we help others? So we do stand the risk of compassion fatigue and burnout. We've got to be very, very careful about that now. In our organization, obviously, we got a lot of first responders there. So some of the things that we do is we got to have, our leadership model it, make a space for people to talk about what they're going through. At Vibrant, we've been doing that in making room for all of our senior staff to talk about how they're feeling. We do that with our Lifeline staff. I'm frequently reminded by my staff, John, you got to take a break, because you got to model for your staff that it's necessary and okay to do that. So I have to remind myself to do that. So it's important for us leaders to model and create a space for that. But I start every meeting, and so many of our leaders start their meeting with first the question, how are you doing? And giving our colleagues, our employees, a chance to talk about what's going on with them first, and then getting into the business, because sometimes it's hard to get business done when you're preoccupied with how you're feeling, it's overwhelmed or whatever. And once you can kind of feel better, as we know in all counseling, you can actually get work done. So being supportive is actually going to help us be more productive. We've also hired a wellness director, not only for our organization, but also for our entire crisis network. So they'll be working with our crisis centers across the network to help them promote wellness and take care of themselves. And we'll also be starting an online peer support group for our crisis centers. So we're taking this very seriously, because we're at a time where we cannot afford to do otherwise.
And may I say also, in addition to how you're doing, it's important to ask specifically how you're feeling, right? And I think about, Anthony Bourdain and Kate Spade, and just recently Jazz Waters, and different celebrities who have passed away by suicide, died by suicide. And in the conversations and discourse and dialogues about their deaths by suicide, invariably it comes up, but they had so much. They were doing so well. And so I also think it's important for people not to mix up the two. You can be doing fine and not feeling fine. And so ask how you're doing, and I know that's common vernacular. That means that's often synonymous. But I think in this time it's very important for us to be very specific about how we're checking in with people, because we can miss some signs, or we can miss some opportunities to really be supportive in a very helpful way and meaningful way.
Absolutely, and then sometimes it's the follow-up question, but how you really feeling?
Yeah,
because
how you really
because you know somebody's hurting. Well, let me ask you this, Dr. Laws. I want us to pivot a little bit. You talked about your work with historically marginalized populations, and considering what we have learned and the events regarding the disproportionate impact of COVID-19 on communities of color, and particularly African American community. And then what we've seen with the deaths of George Floyd, Ahmaud Arbery, Breonna Taylor, and so many others, and the protests that ensued as a result. Can you take a minute just to talk a little bit about the mental health challenges of communities of color and suicidality?
Thank you, Victor, for that question during this time. And also would like to add that today is the 5th anniversary of the massacre at Mother Emanuel in Charleston, South Carolina. Today is the 5th anniversary. So the fact that we're kicking off this series, this very important series on this day, it has some significance. I think that, so I'm a reader of a lot of things. I love poetry, and, Paul Laurence Dunbar's "We Wear the Mask," we wear the mask that grins and lies. It hides our cheeks and shades our eyes. We laugh or we smile. Oh, but Christ, our cries. What you're seeing is the removal of the mask and the raw and unfiltered exposure of what trauma, historical trauma, looks like and how it's played out, right? And you are seeing, I think, in what we're seeing, heightened anxieties among African Americans in particular, but I think indigenous people and people of color who have a reference point in their history that they can point to a time when but by the grace of God, they too could have been a George Floyd. And so we share some of these collective traumas, but for African Americans in particular, with our history of being the descendants of slaves in this country, what you're also, I think, feeling or seeing being expressed, and what some African Americans and other historically marginalized populations are dealing with, increased anxiety, some a sense of hopelessness, but others a sense of hope that we will tear down these systems. We will tear them down, raise them, and then rebuild something better, and something that affirms our humanity, something that affirms the humanity of our children. So you see, I think also this sense of desperation, in the sense that we now no longer have an option of retreating. We are in a desperate state of place in our country. And that causes stress, ongoing stress. Dr. Averitt Moon Parker once said at a Congressional Black Caucus Brain Trust that she thinks that Black people, yes, they experience PTSD, post-traumatic stress disorder, but she coined something called DOTS, daily, ongoing traumatic stressors. And so you're seeing, I think, people with stress overload, and I want to, draw the connection to that and compromised immune systems that makes us more vulnerable to infectious diseases and viruses like COVID-19. And so you're seeing with that, with the overload, the stress overload, the anxiety, and in other instances, depression and so forth. But I think stress and anxiety are heightened and have been exacerbated to a whole nother level. I think that's what we're seeing, or those are some of the mental health challenges that are impacting. African Americans and other people of color. And then also, just trauma, right? So we have a history of being traumatized in this country, and even in the medical profession. Bernard Shaw, and I had to write it down because I can never get it right, but George Bernard Shaw in 1909 in a book, The Doctor's Dilemma, is quoted as saying, "The tragedy of illness at present is that it delivers you helplessly into the hands of a profession which you deeply mistrust." And so you've got people who are anxious and they are sick and they are sick with COVID but they're scared to go to the hospital and to these and trust these systems that have traumatized Black bodies from Sarah Bartman to Henrietta Lacks to Ski. There's a history here that legitimizes and validates some of this fear and this mistrust. So I think you've got all of those things playing out.
So a couple of things. One, we also know that within every population there are subpopulations. Like for example, in the African American community, you also have folks in the African American community who are LGBTQ. And we're not that far removed also from the anniversary of the shooting in Pulse nightclub
right.
down in Miami. And so that's additional stressor. We know that for youth who identify as lesbian, gay, or bisexual, they're 3 times more likely to contemplate suicide, or transgender, 3 times more likely to contemplate, and 5 times more likely to attempt suicide. So we know also that even within these communities of color, there are still sub-communities that have additional stressors and traumas on top of that. But let's stay on that theme of trauma just for a minute, because we've been as a nation really trying to navigate this conversation about race and systemic racism over the past several weeks. And I know that I have been asked several times by my white friends and colleagues, what should we do? What do you want us to do? Tell me about your experience. And while we can appreciate, and I can appreciate as a person of color, people being concerned about that, do we run the risk of re-traumatizing people of color when we continue to ask folks to relive the trauma and talk about those traumatic experiences? And I pose that to the group.
I think we do, and I won't monopolize this, but I think you do, and I also think you place an unfair burden on the victim, right? And I'm not saying victim in the woe it's me, the the one who has the helpless and hopeless. I'm not using victim in that reference or to connotate that, but you're asking me to help figure out how you need to feel about members of your community that, like I said, historically, it's not George Floyd was the match that was struck at this particular time to relight a fire that was still, the kindling was still hot, and he just relit it. So I think it places an undue burden also, not only re-traumatizes, but it places an unfair burden on us to also not only be the wounded, but also to be the healers.
And
Michelle,
the truth is...
Go ahead.
Sorry, John. I was going to say the truth is that we have all been complicit in carrying out and continuing a society that has tolerated these everyday, deep, profound injustices. And so just because some of us in this moment are waking up and paying attention to that does not mean it's new. And so I'm feeling, and we at AFSP are feeling a tremendous sense of responsibility to be part of creating something new, of doing the work to learn more ourselves, and to be very sensitive to, again, the difference between a mainstream perspective and that of living with this day in and day out. And we have to do right by that. It's tricky business, but it can be done. And I think, I was reassured by colleagues recently that the most important thing is just stop being silent, start speaking out, start learning and listening, and then be committed to the actionable strategies that must come next. This will be long-term work. This is not a quick fix. But I personally am very humbled by this experience. I've been, I am realizing the deficits in my own experience and those of many, the multitudes. And it's time to wake up and be done with that. And this, again, it cannot be a short-term type of work. But so we at AFSP are kind of rolling up our sleeves, humbling ourselves in this readiness to learn, listen, gain some expertise from others, and grow and change in the ways that we know we must.
That's right, Christine. It's our responsibilities as people who are white and have some influence among our colleagues. It's really our problem to fix. I'm talking with our Black friends and colleagues. What they've said to us and to me is, I'm tired. I'm tired of talking about what's going on with me or what's happened to me. And, just what I want to see is action. Just having you listen is not nearly as important as just seeing what you're going to do about it. And hearing that, and also just remembering that that many of the things that we have done to make progress has been, fixing our own damn problem. I've one of the things I've been really impressed with, at least with our organization, is just it starts with just realizing that we don't know what to do, but we have to do something. And so, not only creating a space for listening, but most importantly for creating an opportunity to do something. We're bringing in a consultant who's done this kind of work for other mental health agencies in the past to specifically help us deal with anti-racism and establish policies and a culture that is committed to it. And it's also something that we really want to work with and talk with our entire network about. Because it isn't just, we do have this opportunity as leaders in our community to do something about it. So that's the one thing that really heartens. I have to say, it is kind of exciting to be here in this transformational time. It is an opportunity that I think many of us are feeling. And a year from now, I don't want to be talking about the same thing. We've got to be in a different place.
And it's important. It's important for Black children for us to get it right. One, the saying, we don't inherit the land from our ancestors, we borrow it from our children. And so I think for our kids, and tying that to suicide, for Black kids, where we know that we've seen suicide increase dramatically since 2015. And I think for them, that's really where my heart lies right now, because they don't have all the tools to navigate through this. And so it's going to be important that they start seeing some positive, affirming messaging about who they are and how they are valued. And it's also going to be important that we invest in our children's and child mental health systems to be able to help some of the children who are, I think, who are dealing with what's happening in terms of the social and civil unrest, and also with COVID. I've said that underneath the COVID pandemic is a storm that is brewing, and it's called a mental health crisis. And we don't know what's on the other side of this. And so when you add the George Floyd case and tragedy and the social and civil unrest, we really do need to be on the watch for suicide cases rising.
Yeah. One of the things, too, that I think we have to be mindful of those of us who are advocates or work in the suicide awareness space is that, first and foremost, suicide awareness and suicide prevention is about saving lives, and that's about saving all lives. And there are intricacies and nuances that are different and specific to different cultures, and so I do think we have to do a better job in our prevention strategies of figuring out how do we create more strategies that speak to specific cultures. We have a question that's come in via Facebook from CW. With the confluence of several stressors these days, pandemic, societal tension, economic crisis, are there any historical examples of what we should expect during the next 6 months to 1 year for suicide rates?
Let me say a little bit about that. I mean, the quick answer is no, but let me say a little bit more about that. We have a lot of data and models about disaster mental health. What happens to population mental health after disasters. And what we have seen is that there's initially a heroic phase where people rushing in to help the situation. People celebrate our heroes, and then there is the kind of togetherness phase, or the honeymoon phase. I know this sounds a lot like a relationship counseling, but it's kind of a honeymoon phase where we say we're all in this together. And then there becomes this kind of disillusionment phase where people become socially fragmented and start saying, this has really affected me. And as everyone starts to move on and move past this event, the people who are still feeling very affected are feeling increasingly alone. And then as time goes on, those people become increasingly marginalized and kind of lost, and as the rest of people continue to do better. What's different about this is that those disasters were kind of singular events, discrete events where there was a terrorist attack or there was a hurricane. What makes this very different is that it's an ongoing, it's an enduring stressor, and it could recur, which is particularly difficult. And it could also happen while we have hurricanes or mass shootings or other population-based events, and also unemployment and other things that might roll away from this. And there's also this sense of this disconnection that is happening by virtue of this very type of problem. So there's a lot that is making, I think, many of us very concerned about this situation in particular for the long haul. I think it's not to say that things are absolutely going to get worse, but what it does tell us is that we have got to start planning to prepare to prevent problems now, knowing that this is different, and begin installing as much access to care and as many supports in our community as possible.
Absolutely.
Just to tag on to that, John, I couldn't agree with you more. There are many forces that are absolutely threats to population mental health and suicide risk. However, what we know is that suicide risk is multifaceted. And so there are ways to protect against one's risk for suicide, but it requires action, and it requires prevention strategies at a population level so that the most people can have access to that support, the interpersonal support and connectivity, peer support, treatment, to mitigate all of those threats that you so eloquently outlined, John. And so I couldn't agree with you more. If there ever was an imperative that we need to scale up those evidence-based suicide prevention strategies, we are in that moment right now. And the truth is, if we could do that, just like health systems converted over to telehealth services overnight, when they originally had thought that it was either unattainable or was like a 5-year plan to get there, and they did it in 2 days or a week. We should have that sense of urgency about suicide prevention strategies, and we know that they do work, and we have yet to scale them up across our nation.
And when we scale them up, just to add to Christine and John, when we scale them up, we need to make sure that there's equitable access, right? That certain groups aren't benefiting or have access and others don't, because what we're seeing is this compounding effect of long historical negligence of medical treatment and access to care that communities of color have experienced. So when you talk about police brutality, when you and suicide by cop, even when you talk about those kinds of things, when you in many instances there were instances where a person suffered from untreated mental health or substance use disorder that sort of landed them in this horrible way, right? And so or place. And so making sure that there's an equitable that there's access for everyone. We unfortunately in North Carolina are one of the states that didn't expand Medicaid, that could have made health care more affordable or accessible for everyone. And so we really need to have some also serious conversations and policy changes that levels the playing field a little bit with who has access to care.
A couple of I think a couple of points that you all brought out. One, kind of going back, I think, John, to your conversation when you were sharing about kind of what happens in the aftermath of crisis, and I think it as you were talking about that, it kind of took me back to the conversation we were having a little bit earlier about expecting people of color to provide the fix. And I think part of the challenge with that is when you do keep asking people of color to lean in more and more and more to provide the fix, there is going to come a time when the attention span of the country wanes a little bit. And while there still may be some change and there may be some interest in doing away with systemic racism, there's not going to be the attention that we see now. And the more that you pull people of color into that mix and say, help fix this, when people's attention kind of turns to the next crisis, or they start to look at, I want to fix systemic racism, but I'm trying to work on getting my bills back to get my bills back in order. I've been unemployed. I think you run the risk then of re-traumatizing people of color, because they're going to look like you pulled us in with all this energy, and now where's everyone that was going to be involved in the fix? So I do think that's one of the challenges. But the other thing, and Dr. Laws, you talked about some of the involvement with law enforcement. So I want to talk about that a little bit. And John, I want to put this question to you, because one of the issues that has been raised, particularly in the aftermath of a lot of the protests, has been law enforcement. And we've also been seeing for years conversation about law enforcement, how law enforcement responds to people in mental health crisis. So can you speak to 911 and law enforcement response to mental health issues in the community? What would be a model approach?
Well, Vic, thanks for asking. First, sending police for a mental health emergency sounds very early 20th century to me. It's as if we're starting with a presumption that feeling overwhelmed or helpless or hopeless or terrified is likely to lead to a crime or a violence. I mean, if I have a severe gastrointestinal blockage, send me a surgeon. Don't send me a plumber. They typically don't have the right tools or training to deal with the issue. So as a result, a situation that requires caring often ends up being one that creates scaring, potentially adding insult and injury to people who are already psychologically vulnerable. So what we should be doing is sending professionals with mental health training to psychological or mental health emergencies. And right now, they're I believe in about 17% of precincts across the country. There is a model program called the Crisis Intervention Training Program. And in these 2,700 communities across the country where there's still minority of precincts have adopted CIT training, It creates basically mental health training, officers with mental health skills, knowing how to care for people and act supportively and negotiate effectively with people who are suffering and in crisis. And what they found is that those programs have reduced arrests significantly, and they have also reduced physical altercations, which is huge. But most importantly, they have shown to more effectively link people in mental health crisis to care, which is really what it's all about. But aside from sending cops out there, which we should do only to me, only if there are weapons present, we really should be sending out mental health treatment teams, like mobile crisis teams, should be in every community. In fact, in the communities where they've shown mobile crisis teams operating, we've seen significant reductions in encounters with police. In Georgia, over 12 years ago, when they first started putting mobile crisis teams in a number of counties that previously didn't have mobile crisis teams, they saw a 5-fold decrease in police encounters. Also, if you have things like crisis stabilization services, alternatives to emergency departments, the amount of time that police spend with people who are in mental health crisis, if they have to transport them, is reduced significantly, because otherwise they'd go to an emergency department and could sit for 8 hours with them, and nobody wants that. That's not good for anyone, for a cop to be sitting with somebody in an emergency department. Instead, with a crisis stabilization unit, they can drop them off in 5 minutes. So this not only makes it a lot easier for the person who really needs care in a setting that is designed to care for them and provide peer support, but also gets the cop back out on the street fighting crime. It's good for everyone. Also, a number of our crisis lines are starting to work with 911 centers and trying to establish collaborations that can actually divert calls from 911 to our services, which are really about de-escalating mental health crises and doing so effectively. So, for example, one center in Harris County, Houston, a Lifeline center, last year they reduced or diverted about 2,500 calls from 911 to their service, properly de-escalating calls, and saving well over $1 million in first responder money. But more than anything, what they did was save those individuals who would have otherwise had a police response the burden and shame and perhaps even trauma of dealing with people who are not really equipped to work with them in that crisis. So what we need to do is have a crisis and a caring response to crisis, people in mental health crises, not one that is about protecting public safety, but protecting public health.
Absolutely. Anyone else?
No, I was just, yes, I applaud everything that John just said. And even in knowing that there have been instances when people have gone to the emergency department and they've been arrested there, experiencing a mental health crisis. And so I do think that we need to create a better response system and not make that, not criminalize or continue to criminalize mental illness or mental health challenges when people are in crisis.
It's very reminiscent and in a way a continuous thread, a hangover of the past of how mental health was in fact viewed. People with behavioral differences and disturbances were disciplined. It was a punitive approach across the board. It was assumed. And so here now we have science. We're shining a light on the fact that the brain is an organ in the body. It can get sick. We can all express the distress in these external ways, and yet our system has yet to catch up with that. And it is one of the most important and urgent issues that we must deal with. Communities across the country have to build appropriate systems, exactly like you said, for caring and for culturally informed and mental health informed ways, so that people can be relieved of their distress, can connect to help, rather than really escalating the problem into a whole state of, really people are suffering tremendously unnecessarily, and the incarceration and all of that is linked up to this singular issue. I mean, it's multifaceted, but this is a solution that could help.
And again, making sure that we're applying an equity lens to it too, right? Because I think about, speaking of Mother Emanuel, 5 years ago, 9 people killed in the most sacred place on earth, as far as I'm concerned, in a house of worship and faith. Was arrested alive, got treated to a cheeseburger at Burger King, and then taken into the jail. That's not the case of other communities, right? You don't make it home alive, clearly, right? Mike Brown, Tamir Rice, all of the cases that Eric Garner and so forth and so on. And so I say that and link that to the mental health piece of it. We have a commissioner here in North Carolina who represents Durham, Brenda Howerton, whose son was experiencing a mental health crisis and was killed by police. And her passion and her push is always, we want our kids to be treated the same way other people's kids are treated. And so, and especially when they are that vulnerable, when they are sick and need help. And so I just want to make sure that we also, and especially now, stress all of our systems to work in a more equitable and just way.
Yeah, I do want to remind those of us who are joining us online, you can submit questions online if you have questions, and we'll try to answer those. But I want to take a minute just to kind of talk about some of the realities of what people have been facing during the COVID-19 crisis, because we know that access to care for many people has either not been there or looks very different. So for a lot of folks that maybe have had opiate use, opiate addictions, at the most they've been able to maybe get services online, but have not been able to have face-to-face or group services. A lot of the mental health agencies have been closed, or services have been switched to virtual, which we're grateful for, that access. But can we talk a little bit about what we might anticipate that impact being by folks not having had access to services? Because we talked earlier on about the importance of routine. So when that routine, that mental health routine or that, whatever that behavioral health routine is, when that changes and looks different, what is the impact of something like that?
It's an interesting question, Vic, and I'm not sure we know, because in some ways, and Christine mentioned it, we've kind of been seeing a revolution in access to care. We used to think that the only way people could get help, mental health assistance, is in person in an office. On the Lifeline, we've known for years, because research has shown us that on the telephone we can actually reduce emotional distress and suicidality. But insurance, up until very recently, was not routinely supporting or paying for telehealth and telemental health. Now, as Christine noted, overnight, suddenly telehealth, telemental health became the only way to get care. And frankly, about 50% of the people with mental health needs previously were not going to care. And that's also true of people who've been suicidal, who were discharged from hospitals. I can talk about that in greater detail if you want, but they're just not accessing care because we've set up a system that has not been routinely able to be accessed by people. And you could say that, if you're so depressed, and asking somebody who can't even get out of bed to get to a clinic on Tuesday at 9 a.m. is like putting a spinal injury clinic at the top of the stairs. It's just, we didn't set it up for people who are mentally ill, who just can't even leave their homes. Mm-hmm. Yet now we are actually creating a system, or enabling a system. And I've heard from a number of providers who said, I've had some breakthrough sessions. I never thought I could do that on Zoom, but wow, that's been amazing. And welcome to the world of technology, which in fact we have seen evidence has shown that people can really make a sincere and real connection that can make a difference. It doesn't mean it needs to replace face-to-face care, but we sure need to extend our ability to make every means accessible for people to get care when, where, and how they need it, as opposed to how us providers need it. So I just want to put a plug in for this is an opportunity for us to actually extend well beyond the pandemic, a telemental health revolution that we haven't seen before.
Absolutely.
It is an excellent opportunity that we are in right now, and again, it's happening still at a time with the backdrop or within the backdrop or the context of longstanding health inequities and health disparities. And so when we think about telehealth, for example, we are seeing some data. The evidence is suggesting that African Americans and Latinx patients or clients and consumers are not going to follow up visits or using telehealth. So we need to figure out why that is, why we're seeing the largest consumers are white and of telehealth services that are being made available now to address mental health or in response to mental health needs. The other thing is we also know that there still is a difference in technology access. So I wouldn't say the digital divide is as wide as it used to be, but it still exists. So when we think about rural communities versus urban communities, so Victor, you know, here in North Carolina, some of our communities out in the far western part of our state, one of the most beautiful parts of our state is also the most remote part of our state. People are not able to take advantage. And so when we think about seizing this wonderful opportunity, and I think John is absolutely right, it is a wonderful revolution that we are seeing happen in terms of how we deliver care. We need to think about those health inequities too, and how we need to overcome them and make them better.
You know, I do want to add, and then I want to pivot to Christine, but you know, and to your point about us seeing less people of color utilizing the telehealth care, we also have to acknowledge that prior to telehealth in our traditional models, you know, only about half the people who needed care were getting care, and the numbers of African Americans were about half the numbers of whites. So there's something also built into our treatment modalities that is not culturally competent, and we've got to address that too. It's not just whether you can access it virtually or face to face. It's also, you know, what does that treatment consist of? How culturally competent, culturally aware is that treatment? So I think that's important too. Christine, anything you want to add?
Well, no, this is all great. I mean, just 2 points. In addition to that the fact is that if you're someone who feels, and maybe for good reason, has had the experience of not having your experience of coming in and divulging what you're going through to a clinician, having that be either brushed off, misinterpreted, judged, or landed you with a punitive consequence, you know, those are failures of the system and failures of our clinical training models as well, that we have not fully addressed that yet across the board. So that is something that we are advocating for at AFSP. And another one are the workforce issues, and really increasing the pipeline to represent the people of our communities, to be in positions where they can not only provide the care, but help our colleagues to understand what this is about, boots on the ground, because training is essential, but probably not the whole of it in terms of culturally nuanced understanding and care. So, I mean, the last thing that's really been on my mind is, while the legislation around COVID has been fantastic for telehealth, and including the ability for people to prescribe buprenorphine without a face-to-face visit, that was a first time ever kind of change by our DEA. But much of that legislation was written in a way that will automatically revert back after COVID, you know, whenever that is determined to be. And we can't let that happen. We have to at least do an evaluation first to figure out what were the disparities before, what did they look like then, with the offering of these new services in this manner, and then actually improve upon them rather than just taking what I would assume it would be a step backwards.
Absolutely.
Hey, I got to say one more
Sure.
thing about this, aside from amen to everything you're saying. But speaking of amen, where are they going? Where are again, a third of Latinx populations, about a third of they access mental health care about a third of the rate as white people, and as you said, Vic, it's about half the rate for black folks with white folks. It's a huge disparity. But where are they going?
Jail.
And we know they're going. Well, yeah, they're going to jail for sure.
Dying.
They're going to
They're going to
church.
church.
They're going to their faith-based institutions. And the question is, how do we fix it? And certainly, let's divert them from the criminal justice system, Michelle. But Vic, we got to engage the faith-based institutions. That's where they feel trusted and cared for. And we've shut them out of much of our mental health care system. We've not engaged faith-based institutions, and we're all about the same thing, providing a way to provide support and caring for people when they're in crisis.
I 100% agree. I do acknowledge, and having grown up in the church as a preacher's kid, I also acknowledge that historically, the church, the faith-based community may not have always done the best job of dealing with people who have mental health challenges, but that's all the more reason that we need to educate them, partner with them. I have argued from time to time that we have done a fairly decent job of at least trying to integrate behavioral health into primary care and primary care into behavioral health. We need to figure out how to integrate behavioral health into the church, into the community center, into the YMCA. I think that's our next challenge.
I think I'm sorry, Victor, before we end, I think all of our faith institutions, across the board. And I also want to say the church, you're right, has is an important institution, but it has also been the catalyst that has created trauma as well as change. But, and I say that specifically thinking about our LGBTQ population within certain communities, especially within the African American community. They have been, the church sometimes has been the source of its trauma and rejection. And so we've got a wonderful resource. As someone who grew up also in the church, ordained minister in the Baptist faith, we do have a lot of work to do.
We do. And the reality is, folks are still going to the preacher whether they know what to tell them or not. So we gotta deal with that.
That's right.
So this hour has flown by. I cannot thank you guys enough. I could sit here and talk with you all day, but I do. Before we close out, I do want to give each of you just a moment for any closing comments that you may have, anything that you want to leave with our audience. Let's start with Christine.
Sure, great, thank you. Really, what a rich conversation. Thanks to all of you. I'm learning as we go as well. I think for anyone out there, you may have been able to be up here on this panel and say these things, and I'll humbly admit, living it out in our daily lives can sometimes be a different matter. And realizing that when you're in those dinner table conversations, or you sense that somebody in your life is going through a rough patch, and you have a decision to make about how to handle that moment, just remember, we tend to underestimate the power that we have in each other's lives. And just centering yourself enough to be present in that moment, to speak with somebody in a caring, loving, and non-judgmental manner, it may be their first step, their first opportunity to disclose that they're going through what could have been a life-threatening suicidal crisis. And it's much more common around us than we realize. And so I would just embolden all of us to keep that in mind in our sort of moment-to-moment daily lives. And, about the time that we're in, related to COVID, related to racial disparities and systemic racism, I would just encourage all of you, as I'm trying to steady myself in this moment, that it's okay not to have all of the answers. What is important is that you stay present, you keep listening and learning, and you take action in a way that your conscience guides you, and that we do that together collaboratively, and we don't get sucked into that natural impulse that will happen. This will be yesterday's crisis soon enough, but it cannot end. The actionable strategies will have to continue long after that sense of kind of societal urgency that we're feeling in this moment.
Michelle?
One, I want to thank you, and it has been a pleasure to share this space and time with Christine and John. Just a wonderful conversation, and learned a lot just in thinking about where we are, and if I can leave any words of encouragement to people who may be feeling a sense of hopelessness. One is always fight and for tomorrow. Always try to live and make it one more day. And I say that as someone who lost a brother-in-law to suicide and a sister in a murder-suicide. And so, and who, as someone who myself have felt like, tomorrow, the weeping endured for the night, but joy comes in the morning. That morning will never come. I want to encourage you to keep pressing and pushing towards that morning, whatever it is. I want to also say that we are stronger together, that all of us collectively in our communities working together we'll make it through on the other side of COVID. We will make it through on the other side of this social and civil unrest in a better place if we believe in what Dr. King said, that love always overpowers hate. And in the end, it's what we do, how we take care of each other in our local communities, those that we have direct contact with, that we need to focus our attention on the most. Build that beloved community from the ground up, and then fight for more mental health funding and policies that are humane and just and that help people to heal and stay in recovery.
Thank you. And John?
Vic, it's been great. Thank you so much for hosting this. It's been wonderful spending time with Michelle and Christine. This is just a very surreal moment in our lives. Really right now, we're talking about reopening the economy after people have been told to be scared. Everybody be scared and go get in your house now. And now we've got to reopen our minds. We've been, imagining going to a packed restaurant now. And even walking down the street and seeing somebody without a mask can be scary for people. It's interesting that I've been talking with, I have a private practice, and hearing, my clients who've had a long history of anxiety who say, hey, welcome to my world now. This is what I've been living with every day. I was talking with a friend and colleague who has a history of paranoid thinking. And he was saying, yeah, I've been suspicious of people all my life. Welcome to my world, because now we are all saying, is that person going to infect me? So this really is an opportunity for us to sit back and think about, what is important to us, and how do we engage what's important to us in a way that can be change making. So if we've had our connections taken away from us in a traditional way, and we've had in some ways our work taken away from us in traditional ways, and we've had a chance to think about what's meaningful to us, as we reopen this economy and reopen our minds, how can we also use this as an opportunity to seize transformation? And us folks in mental health can certainly be thinking about how we can take what germs of learning that we're getting, and some of the progress we're actually making, such as in telemental health, and how can we grow this? How can we also take this social justice moment to say that it's not just about social justice for what's right, but also what's better and what works, because we know that by creating greater equity creates greater strength and actually more effectiveness in terms of everything we do. So this is really an opportunity, I think, for us to make change in ways that our kids and grandkids can be proud of. So let's keep up the good work, y'all.
Absolutely. Thank you. I cannot tell you how much I appreciate you all being with us today, both to the folks who joined us online and especially to our panelists, to Dr. Christine Moutier, Dr. John Draper, and Dr. Michelle Laws. Thank you so much for being here. I wanted this first conversation in this series of 5 to take place with the three of you because I admire your work and I admire your passion. Michelle, your work in working with historically marginalized populations, I get to see that up close and personal, and I'm a huge fan of your work. Christine, the work of the American Foundation for Suicide Prevention. Again, thank you so much for what you all do every day. I follow you closely, listening to the wisdom and knowledge that you put out around suicide prevention. And of course, John, who is one of the pioneers in terms of providing a safe place for people who are experiencing suicidal ideation. So thank you all so much for being with me today. And I want to leave everyone with this. If you're listening to us, I want you to know that you matter, your life matters, you are enough. If you're experiencing mental health challenges, get help. If you're in crisis, you can call the National Suicide Prevention Lifeline at 1-800-273-8255. That's 1-800-273-TALK, or you can text 741-741, because most importantly, we want you to be here tomorrow and every day after that. Thank you for being with us.